Good afternoon, friends. Today, my topic is in cardiology, the approach to pericardial diseases. I'll be just sharing you overview of pericardial diseases. So, the pericardium is actually the layer covering the heart, the outer surface of the heart, and it has a parietal, outer parietal pericardium and a visceral pericardium. So the outer parietal pericardium and the visceral pericardium, and in between that there is a pericardial space, and which has pericardial fluid. Normally, it is about around 50 ml, and it is like the serous, and it is like the fluid is actually like a plasma, and it is lymphocyte predominant. So it is like a actually it is slightly like an exudate. That's why when we do pericardiocentesis and we don't take Light's criteria, because it is already like a exudate kind of thing. Okay. So pericardium, it assumes importance only when it is diseased. So the two things which are important here is it restrains the cardiac volume after a particular point of time, and then there is ventricular interaction when the pericardium is diseased. So the pericardium is diseased, there is ventricular interaction between the RV and the LV. There are other functions of the pericardium. It is like a barrier to infection, and then it maintains a heart position. It has a lubricant function, pain perception through the phrenic nerves, which is there, and that's why in pericarditic pain you get radiation to the back and all, to the trapezial ridge. And there are mechanoreceptors, chemoreceptors are also there. It is a source of prostaglandins, which which acts as for neural traffic, and for it maintains a coronary tone. And then there is another thing called transverse sinus of the pericardium. If you see here, there is a cul-de-sac kind of a transverse sinus, which is actually among the three. This B is correct. The cul-de-sac behind the great vessels. So behind the great vessels, that is the aorta and the pulmonary artery, the aorta and the pulmonary trunk, is the transverse sinus of pericardium. Why it importance? It is important for the surgeons actually. While doing a coronary artery bypass graft, or for any surgical importance actually. So what they do is to catch the pedicle of the aorta or the pulmonary trunk, they actually locate the transverse sinus for that. There's another sinus called the oblique sinus also. Now coming to disease of the pericardium. So it is actually, I will be talking about pericarditis, that is acute pericarditis, and then chronic constrictive pericarditis. Then I'll be talking about cardiac tamponade, pericardial effusion, and then malignancy also can be there involving the pericardium. So in pericarditis, the most common cause is actually idiopathic actually, or it is viral. It is the most common form of acute pericarditis, around 80 to 90%. And it is in idiopathic pericarditis, it is not a large, it doesn't have large effusion. It will have some small effusion, pericardial effusion associated with it, or moderate effusion, not large effusion. And then metastatic cancer. So metastatic cancer usually from the close to the heart only, lungs, breast. So these are the common primary for this metastatic cancer in the pericardium. And then connective tissue disease, most commonly we see is SLE, rheumatoid arthritis. And then infections common in our developing countries is tuberculosis, HIV, bacterial, fungal is rare, Lyme disease. The other common causes of pericarditis, the inflammation of the pericardium, which we see in our clinical practices, uremia in chronic kidney disease patients, CKD patients, radiation. Radiation is now not that common, because now with the new technologies, they are trying to avoid radiation more to the heart and preventing this complication in the pericardium. So, but especially radiation, when it is given for Hodgkin's lymphoma and all, that time they can, and it is actually a long term. After many years of radiation, people can have this radiation associated pericarditis. Post MI pericarditis, we see in acute, it is classified into two things. One is early acute pericarditis, and then after 1 to 2 weeks, that is called Dressler syndrome. So the one which occurs later is an autoimmune condition actually, Dressler syndrome, post MI pericarditis, and then the acute one is it happens within 1 to 3 days. Post cardiac surgery, cardiotomy, and during CABG, they also can have this pericarditis and pericardial effusion. And direct injury to the heart, blunt trauma, can cause this pericarditis. And then even in causing aortic dissection, and then that can also cause pericarditis and pericardial effusion. So this is just whatever I told before. But the common things to remember is viral or idiopathic pericarditis, which is usually sometimes it is self-limiting, and then it gets better. That viral pericarditis or idiopathic pericarditis becomes better with NSAIDs like Brufen or aspirin, high dose aspirin, and then that treatment will be coming later. And then if it is not getting better with that, we can add colchicine also. So then etiologies of pericardial diseases, same thing. So the viral actually Coxsackie virus, echovirus, adenovirus, these are the common viruses. In the era of COVID-19, they have not found that much of literature articles pertaining, like affecting especially the pericardium. Then autoimmune, as I told, SLE and rheumatoid arthritis. Neoplastic can be primary or secondary. So primary mesothelioma, fibrosarcoma, lipoma. Secondary or metastatic, especially from lung cancer, breast cancer, and Hodgkin's lymphoma and Kaposi sarcoma. Now, so how a patient presents with acute pericarditis? So there are some criteria among the four. This thing 1, 2, 3, 4. If two are there, it is actually we can diagnose there's a different acute pericarditis. So the first is the history. So in history, actually, the pericardial chest pain. So in any chest pain, if a patient comes to the emergency, it can mimic a MI also, and it can be a silent MI which was missed, and then now patient coming with pericarditis like that also. So any chest pain for that matter, you can there are ways to remember, like Socrates or old car. So the onset of the chest pain, the location, the duration, the character, and the associated factors, the aggravating factors, the relieving factors, and whether it is associated with radiation or not. So just to remember, old car, OLDCAR. So onset is acute onset, and it's like a scratching, and it is a very it can mimic a MI. It's like a severe pain which can actually, it becomes worsens while lying down. Actually, worsens are lying down, and then it can radiate to the back and even to the trapezoid ridge. They say classically to the trapezoid ridge. This pericarditic pain. Pericarditic pain typically increases on inspiration, and you can clinically hear a pericardial rub. Pericardial rub will be heard when there is not much of fluid. So once the fluid collection starts, the pericardial effusion, then you can't hear the rub. So it is like waxing and waning. That pericardial rub, sometimes you may hear, sometimes you may not hear. Pericardial rub is classically heard in the lower left sternal border, in the leaning forward position, in the patient in sitting position. The ECG changes in pericarditis, there is actually stages also is there, and sometimes there is a classical evolution of the pattern of the STT changes in pericarditis, and sometimes it need not be like that. But the classical things are like, there will be the most common, which is mentioned in Brownwald, is diffuse ST elevation. Diffuse ST elevation in almost all the leads except in the AVR. So that can be a clue for this acute pericarditis. So that means it doesn't respect a territory. If it is an anterior wall MI, it will show ST elevation only in the anterior precordial leads, V1 to V6. If it is an inferior wall MI, 2, 3 AVF in ECG. But if it is a acute pericarditis in a ECG, it will be like diffuse ST elevation. And there is another thing is there won't be any reciprocal changes, which you find in, for example, in acute anterior wall MI, there will be reciprocal ST depression, ischemic changes in the inferior leads. But those things will not be there in the acute pericarditis. And then PR interval, the PR depression also is a classical sign. PR depression will also be there in almost all the leads except in AVR. In AVR there will be this is called knuckle sign. So if you see the knuckle, the shape like this. So especially in AVR, there will be a PR elevation actually. But in all the other leads, this is the QR interval, QRS complex. So this So this PR depression is a classical of acute pericarditis. They say it is very specific also, this PR depression, and it's the earliest one of the earliest sign of acute pericarditis. So PR depression you can see almost in all the leads. And here in this ECG, you can see even ST elevation, which is there almost in V2 to V6, and even it is there in inferior leads. So ST elevation is there in inferior as well as anterior leads. And here you can see knuckle sign, that is PR elevation, which will give you a clue for possibility of pericarditis in the ECG. There is another sign called spodic sign, which is a downward TP segment. So PQRS T wave, and then this T wave, and this is a P wave. So this down sloping TP segment is called the spodic sign, which is also described in 30% of the patients with acute pericarditis. So in acute pericarditis, there is a major and minor criteria to say for whether it is a poor prognosis or not. So the major things are, which are predictors of poor prognosis, are high grade fever of more than 38 degrees Celsius and a subacute course. The symptoms, it happens over several days without a clear cut acute onset, large pericardial effusion, cardiac tamponade with hemodynamic instability, failure to respond to NSAIDs, which is given for 7 days, and the patient doesn't respond to it, still continues to have symptoms. So these are all predictors of poor prognosis. So that's what we see here, predictors of poor prognosis, the major and the minor, which I described as major. So in any pericarditis, physical examination, history, physical examination, very important. ECG, chest X-ray, sometimes it may not give any, it may be normal also. There may not be any, but sometimes there may be some lung infiltrates or associated with lung infection. Echo, I'll come to it. So echo, they may have some pericardial effusion, which will give a clue. C-reactive protein and troponin, either HSCRP, it is available, or CRP will tell you the disease activity. So CRP will, if it is increased, then it is suggestive of acute pericarditis. Either an ESR also can be taken if CRP is not available. Troponin elevation usually is will be very high in myocarditis, but in pericarditis there may not be that much elevation. So if there is these symptoms of and signs of pericarditis, if the etiology is highly suspected, then if the patient is sick, then you admit, or if the patient is not that sick and hemodynamically stable, we can even give an empirical trial with NSAIDs, and then we can follow up in the OPD basis also if it is a low risk case. But if the patient is not recovering, and then if he is deteriorating, then better to admit and then search for etiology. So diagnosis of acute pericarditis, 2 out of 4 clinical criteria: pericardial chest pain, pericardial rub, ECG changes, and pericardial effusion. In pericardial rub, it is actually the sound, the auscultatory sound which we hear. It has 3 components actually, which they ask in exam. So one is a systolic sound and a diastolic sound, and then there is another scratchy sound which is here in this pericardial rub classically. So the first line of treatment will be giving high dose of aspirin or NSAIDs. NSAIDs, ibuprofen 600 to 800 milligrams thrice daily. Aspirin high dose 1 gram Q8H. Now between aspirin and NSAIDs, if the patient is pregnant, less than 20 weeks of pregnancy, we can give NSAIDs. But after that, we better not to give NSAIDs, because it can close up ductus arteriosus. So during that time, we have to give aspirin high dose, which can be given during pregnancy. And then if it is not responding to that, then we can give colchicine. Colchicine is an add-on drug. It's an anti-inflammatory drug. Basically, why they have different mechanism of action of this colchicine, which I'll be telling you. So if not responding to aspirin and NSAIDs, you can add on to colchicine. And if that is also not responding, we should not initially start with steroids. The steroids should be started later. If they're not responding, it's a second line actually. In case if aspirin and the NSAIDs are contraindicated, that time we can combine colchicine as well as corticosteroids, low dose steroids from 0.1 to 0.2 mg per kg per day. So if the patient gets better, then we can follow up in the OPD basis in the acute pericarditis. But sometimes what happens is after a symptom-free period of 4 to 6 week interval, the patient can still again come back with similar kind of symptoms. So that is termed as recurrent pericarditis. So in recurrent pericarditis, again, the first line is exercise restriction, aspirin, colchicine, and then adding on steroids. So this is called triple therapy. Triple therapy is aspirin or NSAIDs, then colchicine, then corticosteroids. That is also not working. Then IVIG, and nowadays anakinra or azathioprine also can be tried. The fourth line is finally it is pericarditis. So the doses of aspirin, ibuprofen, and colchicine are given here in this table. So initial duration 1 to 2 weeks, aspirin, brufen also 1 to 2 weeks. Colchicine should be given for 3 months. And after that, actually you repeat a CRP to see whether he is responding to NSAIDs and colchicine. So if there is a downward trend of CRP, then you taper you don't abruptly stop. You don't abruptly stop NSAIDs. You have to gradually taper and then over 2 to 3 weeks and then only discontinue. So abrupt tapering is not, it should not be done. So about other drugs like anti-inflammatory drugs which I mentioned, one is anakinra, then colchicine, azathioprine, and IVIG. So anakinra, what it does is it is an interleukin antagonist. So interleukins are inflammatory mediators, which are so it inhibits actually the interleukin-1. And there is another drug called rilonacept. So rilonacept actually what it does is it traps the interleukin-1 to reduce the interleukin and reduces the interleukin-1 activity. So in the inflammation, as we know, activated monocytes, macrophages, granulocytes, T cells, B cells are activated. So to inhibit this, only these drugs are tried. Colchicine actually it interferes with the microtubules actually. It blocks the tubular polymerization, and then that's why in that way it reduces the inflammation. Azathioprine it blocks the purine and DNA synthesis and inhibits lymphocyte proliferation. And IVIG, what it does is it increases the clearance of the infectious agents. It acts like an immunomodulator. It modulates the adaptive and the innate immune systems and increases the clearance of the infectious agents. So these are the drugs which has to be tried. Especially anakinra, rilonacept, azathioprine, and IVIG. If the patient is not responding to the NSAIDs or aspirin or colchicine and corticosteroids. So the ESC, the European Society of Cardiology, recommendations for diagnosis and management of pericarditis. So pericarditis sometimes it may not be isolated; it can be associated with myocarditis also. So in a case of pericarditis, suspected associated myocarditis, if there is myocarditis, what will happen is there will be troponin elevation, and that time sometimes we may need to do coronary angiogram also to look for any coronary involvement to rule out any acute coronary syndromes. And then cardiac MRI also is recommended for confirmation of myocardial involvement. And whenever there is myocardial involvement, better to admit the patient because it can go into hemodynamic instability and patient can deteriorate. And then avoid physical activity. And beyond normal sedentary activities, patient is advised for complete rest for at least a period of 6 months. So this is about pericardial effusion and impending tamponade. So patient has a pericardial effusion. So how do we know patient has a pericardial effusion? Only by echo we can see, or X-ray, chest X-ray. Sometimes the chest X-ray it is difficult to, cardiomegaly will be there, but sometimes it is difficult to make out. So after an echo, if there is a pericardial effusion, it can be mild, moderate, and large, or it can be very large. So it is like if it is more than 20 millimeters above the right ventricle, it is a large pericardial effusion. That will show you in some pictures, and which will need actually pericardiocentesis. Either one is diagnostic to see what is the cause for that pericardial effusion, and after that therapeutic also. Sometimes we put a pigtail, insert a pigtail for continuous for drainage intermittently. For 2 to 3 days, we can keep the pigtail if it is a large pericardial effusion. So the large pericardial effusion it can go into impending cardiac tamponade and cause hemodynamic instability. So that's why we have to put a pigtail for all large pericardial effusion if patient is hemodynamically unstable. Coming to constrictive pericarditis. So constrictive pericarditis it is actually what happens is the pericardium it becomes there is fibrosis, inflammation, fibrosis because of acute pericarditis which is untreated sometimes. and then that fibrosis actually it causes thickening of the pericardium, and that thickening causes calcification, scarring, ultimately, and loss of the normal elasticity of the pericardial sac. So because of that, what happens is the heart is encased in a very like a coconut shell, like a tight shell. So that causes actually diastolic dysfunction. So diastole during the ventricular relaxation, the blood has to go to both the ventricles, the LV and the RV. But what happens here is there is impairment in the ventricular filling. So that is classical in constrictive pericarditis. It leads to impairment of ventricular filling, especially in mid and late diastole. So it is a diastolic phenomenon, diastolic dysfunction. Normally, we think that the systolic function of the heart is only important, but diastolic function is equally important, if not more. So diastolic, in diastole, actually, there is an early diastole where there is early filling. The early filling of the right atrium, the blood goes to the right atrium and then open, the tricuspid valve is open, and then that enters the right ventricle. So in the early filling will be there, which will happen in constrictive pericarditis. But after that, when there is early filling, there is abrupt like there is an impairment of the ventricular filling beyond that. So there is impairment of ventricular filling in mid and late diastole. So the diastolic phases we should remember is like early filling, then there is a late filling, then there is a diastasis, and there is a atrial contraction. So as a result, what happens is the majority of the ventricular filling of the RV and the LV, actually RV is more filled during the inspiration. So the majority of the ventricular filling happens in early diastole, and the ventricular volume does not increase after the end of the early filling period. It remains like that. And though the prognosis is dependent on the underlying etiology, so commonly in our country, tuberculosis etiology is commonly we see history of TB, untreated or treated tuberculosis. So they say even if tuberculosis treated for giving ATT for 6 to 9 months in a TB pericarditis, around 20 to 30% can go into this constrictive pericarditis phase. So they recommend actually 9 months of treatment for ATT treatment for TB pericarditis, and not beyond 9 months, because it's not needed and it doesn't work beyond 9 months. So though the prognosis depend upon the underlying etiology, complete surgical removal of the pericardium is the final treatment for constrictive pericarditis, and that can sometimes result in excellent symptomatic improvement. So there is some differences between constriction and tamponade, cardiac tamponade. So here we see there is a shift of the RV during inspiration. So during inspiration, what happens? The intrathoracic pressure decreases and there is increased venous return. So during increased venous return, so there is early filling which will happen in constrictive pericarditis, and after that there is what happens is, if you see in this picture, so the RV is filled, and after some time, because of that pericardial thickening, it will push the interventricular septum to the towards the LV, and the LV cavity, the LV volume is reduced. So there is actually it is called a LV-RV discordance or ventricular interdependence. So this ventricular interdependence is very classical of constrictive pericarditis, and the opposite happens in expiration when there is filling of the LV from the LA, and then there is push of the interventricular septum towards the right. So this is called ventricular interdependence, which is classical of constrictive pericarditis. There are other features of constrictive pericarditis, which like pulsus paradoxus, which will be there in approximately 1/3 of the patients. But in tamponade, it will be you will be able to clinically pick that up. So in pulsus paradoxus, what happens is when you are measuring the BP, for example, the beep when the correct sounds you are hearing, systolic from 150, and then abruptly after that you're not hearing the correct sounds, and again it appears from 130, for example, and then then you are able to hear the correct sounds after less than 130. So that from 150 to 130, that is especially during inspiration it happens. So that is a paradoxical pulse. So if it is more than 10 millimeters of mercury, then it is suggestive pulsus paradoxus. Then there is other sign called square root sign in constrictive pericarditis, which it will be present there. That square root sign actually, which we see in hemodynamics, when we see the hemodynamics in cath lab, that is actually similar to the rapid Y descent, what we see in clinically in JVP. So this is a echo picture which shows a trivial pericardial effusion. So here we may not be familiar with the echo. So this is the left atrium, this is the left ventricle, this is aorta, and this is the right ventricle. And this is the parasternal long axis view. The arrow mark which is put here, this is the pericardial effusion. So the pericardial effusion here, it is this trivial. Here it is small, moderate, large. So large is if it is more than 20 millimeters, especially above the right ventricle, So this large pericardial effusion can go to impending tamponade, where there will be RA and RV collapse. So the earlier thing is the earliest is the RA collapse, and then afterwards there will be RV collapse. So the same thing you are seeing in the parasternal short axis view, the pericardial effusion. So this is the left ventricle. Though this thing is the left ventricle, and below this is the pericardial effusion. Now here we see there are two black shadows you are seeing. So actually this is up to here only is a pericardial effusion. Below this is a pleural effusion. How do we say that? It's because this is the cut section of the descending thoracic aorta. If you see, this is the aorta actually. This is the aortic valve, and this aortic valve, the ascending aorta arch will come like this, and then it will come like this. So this is the cut section of the descending thoracic aorta. The point is that if it is adjacent to this, this is the pericardial effusion. If it is below this descending thoracic aorta, it is a pleural effusion. So that's how we identify whether it's a pleural effusion or pericardial effusion by echo. If it is a large effusion, sometimes it can happen. They can have both like this. So large pericardial effusion will have swinging of the heart, pendulum movement of the heart. So that is like called alternance, which is picked up in the ECG like electrical alternance. So this is in patient going into impending tamponade. So this is the right atrium, this is the right ventricle, left atrium, left ventricle. Here we see the earliest in cardiac tamponade will be the indentation of the fluid into the RA. This happens actually in systole, early systole. And after that, there will be RV diastolic collapse. So this happens in early diastole. So RV diastolic, this happens in early diastole, this happens in early systole. RA collapse happens in early systole, RV collapse happens in early diastole. So when you are picking up when there is RV diastolic collapse, this is the time we have to intervene. Otherwise, the patient will go into hemodynamic instability, hypotension, shock, and all. Patient can collapse. So we have to do immediate urgent. This is an emergency where we have to do a urgent pericardiocentesis and then evaluate for the cause for that tamponade. So constrictive pericarditis can be either a transient constriction or a effusive constrictive pericarditis. Effusive constrictive pericarditis means constrictive pericarditis associated with some pericardial effusion also, and there is chronic constriction. So constrictive pericarditis can sometimes mimic cardiomyopathy, restrictive cardiomyopathy, because they both can have a diastolic dysfunction and restrictive physiology. All constrictive pericarditis have restrictive physiology, but not all restrictive physiology have constriction. So chronic constriction is persistent constriction after 3 to 6 months, where in spite of medical therapy, it's failed, and then patient has to undergo a pericardiectomy for advanced cases. So this is a spectrum of constrictive pericarditis, recurrent pericarditis, which is transient, treated. Then there is some subacute phase. Ongoing inflammation is still there. Then gradually it is going into chronicity, and then after that there is burnt out constrictive pericarditis. So in spite of treatment with NSAIDs and plus or minus biologics, sometimes they may go into chronic constrictive pericarditis. So here this is actually the cardiac MRI images. So cardiac MRI images, there are two things to look for. One is the delayed hyper enhancement. DHE is delayed hyper enhancement, and another thing is the T2 stir images. So this is the heart. So here we see this is the calcification. So this white thing is the calcification which we see in the early acute phase, and then afterwards when it is burnt out, we are seeing actually it disappears. The delayed hyper enhancement is also we are not able to see much. the delayed hyperenhancement is not there, and then even in T2 stir images, you're not able to see that that the LG pattern, that hyperenhancement, which we are supposed which is seen in the early stages. So this is a for a clinic in a clinically in a patient, when you're examining these three things, better to remember. So in a patient, when you are seeing a patient comes with heart failure, so in constrictive pericarditis, you usually have a right heart failure. So right heart failure, there will be actually there will be ascites and there will be pedal edema. So there is a condition called ascitic precox, where there will be ascites is disproportionate to the pedal edema. So it's not that pedal edema will be completely absent, but it may be lesser compared to the abdominal distension. And then because of the there's no impaired, there is impaired RV filling. So what happens is during inspiration, usually what happens is the JVP should fall. That is called small this thing, small sign. The small sign is actually during inspiration the JVP is actually increased, or it is not reducing. So that small sign, it is classical in constrictive pericarditis. Small sign you don't find in cardiac tamponade, but you find in constrictive pericarditis. Here in a patient with heart failure with elevated JVP, so you see the pericardium. It is there is a hyperactive pericardium or is a quiet pericardium. So in a pericardial effusion or in a pericardial disease, if it is a quiet pericardium, when there is no murmur, there is no gallop, then there is a possibility of it is a pericardial disease. If it is a hyperactive pericardium with murmur is there, then you think of valvular heart disease. If it is hyperactive pericardium with prominently gallops, that is added sounds, then you think of myocardial disease. In pericardial, constrictive pericarditis also, you can have diastolic sound. Classically, you hear a pericardial knock. So pericardial knock is actually, it is a diastolic event, which happens actually before S3. Sometimes they say within brackets S3, but it is actually just before S3. You can remember the mnemonic OKT3, OKT3. So these are the diastolic sounds. They will ask what are the diastolic sounds in the order of their occurrence. So in the diastolic sounds, the O is the opening snap, which the initial which occurs. Then after that, K is the knock, and T is the tumor block, and then 3 is the S3, the third R sound. So in this order only the diastolic sounds occur. So constrictive pericarditis, elevated JVP in around 93%, pulses paradoxes, a small sign, pericardial knock, and then profound cachexia. This cachexia happens because of reduced cardiac output, because of impaired LV filling, and then reduced cardiac output. So there'll be, and then this peripheral edema, ascites, pleural effusion happens because of increased hydrostatic pressure in the vessels, because the blood is not entering the RV. So what happens is there is backflow, there is in the IVC, in the SVC, there is increased pulmonary flow, there is increased systemic flow. So that causes increased hydrostatic pressure in the vessels, the blood vessels, and that causes shift of the fluid to the either pericardial space or pleural space, and then in peritoneal causing ascites, pleural effusion, ulcerative hepatomegaly. So these are the findings clinically in constrictive pericarditis. So here you see in the chest X-ray, especially in the lateral view, you can see the pericardial calcification. So pericardial calcification is in constrictive pericarditis, when you are doing an echo, there may not be calcification in 18% of the patients. If you do a CT scan, in around 20%, you may not find calcification. So calcification, if it is not there, doesn't mean that it is not constrictive pericarditis. So calcification alone should not be the criteria. But this pericardial thickening, which they measure in CT scan, normally the pericardial thickening is around 2 millimeter only. If it is more than 4 millimeter, then we should suspect this constrictive pericarditis. So between CT versus MRI, CT is better actually. If you are thinking restrictive cardiomyopathy, which is a disease of the myocardium, then you go for MRI rather than CT scan. And then to differentiate between it is a cardiomyopathy or a constrictive pericarditis, BNP also will be helpful. This NT-proBNP will be elevated in myocardial diseases rather than constrictive pericarditis. Why? Because in this brain natriuretic fabric is released when there is a stretch of the ventricles. So when the myocardium is affected, so in that time the BNP will be elevated. But BNP is not that much. It is very normal. It won't be elevated in constrictive pericarditis. So again, this is actually the hemodynamic tracing in cath lab. So here we are this one is a left ventricle LV pressure, and this is the pulmonary capillary wedge pressure. So pulmonary capillary wedge pressure, as you know, refers to LA pressure. So and this is this constrictive pericarditis. The term respirophasic is very important. So there is a respirophasic variation, that is during inspiration and expiration. There is a variation which happens in constrictive pericarditis, unlike in restrictive cardiomyopathy. So during inspiration, what happens? There is during inspiration, what happens here? You see the arrow mark here. So the RV filling occurs. It pushes the interventricular septum towards the LV, and then there is a less LV filling. So then there is a interventricular dependence, which is very characteristic. And then it causes actually septal bones. So there are two terms: septal shudder and septal bones, which we see in echo. So here in this echo, this is a LA, this is LV, this is RA, this is RV. So here actually they are measuring the septal velocity in a pulse wave Doppler. So when we do echo, so this is a septal part of the mitral valve. This is a mitral valve. This is the septal part of the mitral valve, and this is the lateral part of the mitral valve. So this is a medial annulus, and this is a lateral annulus. So in constrictive pericarditis, what happens is this pericardium is thickened, no? So the movement of when the LV contracts, the movement in the lateral side. So this will be less. Normally this is more, this is less. But in constrictive pericarditis, what happens is this septal velocity will be more. Here it is 18 centimeter per second, and this lateral velocity is 15 centimeter per second, which should raise a suspicion of constrictive pericarditis. So this is called annulus reversus. So the lateral velocity is reduced compared to the septal velocity, which is called annulus reversus, which is classical in constrictive pericarditis. Another terminology is called annulus paradoxus. This is because the thickening of the pericardium, so that is causing this annulus reversus, which will not be there in restrictive cardiomyopathy. Because in cardiomyopathy, it is a disease of the myocardium. In the restrictive cardiomyopathy, not the disease of the pericardium. And in CT scan, you can see the pericardial thickening and calcification also in constrictive pericarditis. So this hyperlucent thing. There are so many things in hemodynamic and hemodynamic features in constrictive pericarditis to differentiate between restrictive cardiomyopathy. So not one thing alone will we can say that it is pathognomic of constrictive pericarditis. So just for your understanding, so this is the RV pressure which we measure in cath lab, and this is the LV pressure. So in the LV pressure and the RV pressure, so here we see during inspiration. So what happens is during inspiration, the RV pressure increases. So this is the RV. During inspiration, the RV pressure increases, but at the same time, what happens is the systolic pressure, the LV pressure, the LV filling pressure. Sorry, the LV filling pressure, it reduces. See the height of this LV, it reduces, and you see the area also. This area also. During expiration, what you see here, it is not like that. So this is called ventricular interdependence. So ventricular interdependence means, so this RV pressure increases, but the LV filling pressure doesn't increase. So this ventricular interdependence is characteristic of constrictive pericarditis, which we don't see in restrictive cardiomyopathy. This is restrictive cardiomyopathy. This is constrictive pericarditis. The above one is constrictive pericarditis, where we see ventricular interdependence, and we calculate the systolic area index also. So this systolic area index, if it is more than 1.1, it is suggestive of constrictive pericarditis. And this in JVP, if you superimpose the JVP here, this is a rapid Y descent. This rapid Y descent which we see, which happens in constrictive pericarditis. The square roots can still be there in restrictive cardiomyopathy, but it is commonly described in constrictive pericarditis, where there is a rapid Y descent, and this is because of the rapid Y descent because of the early filling of the RV, and after that there is actually a plateau phase. So this plateau phase, where there won't be any there is impaired filling, so causing a square root sign, which is present in constrictive pericarditis. In restriction, it is variable. So other things are, so the prominent Y descent, which is said in constriction, constrictive pericarditis, constriction versus restriction. Now constriction versus cardiac tamponade, the rapid Y descent will be absent in cardiac tamponade, but the exit descent will be preserved. So exit descent is preserved in cardiac tamponade, but the rapid Y descent will be absent in cardiac tamponade. Pulsus paradoxus, which is absent in restrictive cardiomyopathy, but it is there in constrictive pericarditis. Pericardial knock is there in constrictive pericarditis. The filling pressures beyond 25 millimeters of mercury, the LV or RV filling pressures is rare, but it is common in restrictive cardiomyopathy. Square root sign, then pulmonary artery systolic pressure also, it doesn't exceed more than 60 in constrictive pericarditis. The another finding in restrictive cardiomyopathies, in echo you will be seeing biatrial enlargement. So biatrial enlargement is very characteristic of restrictive cardiomyopathy, which you won't see in constrictive pericarditis. There may be possible left atrial enlargement, but classical biatrial enlargement will be there in restrictive cardiomyopathy. In restrictive cardiomyopathy, it will be another big topic where cardiac amyloidosis, sarcoidosis. So all these things, entities will be you have to look for. What is the cause for that restrictive cardiomyopathy? Septal bones classically is present in constrictive pericarditis. Septal bones is nothing but a septal jerk of the interventricular septum. That is because of the ventricular interdependence that is causing the jerky septum, the septal jerk, and the septal shudder also they mentioned. And there is a speckle tracking imaging also. In speckle tracking, they say the normal long tunnel strain, the long tunnel strain is reduced, whereas the circumferential is restored, which is opposite in restrictive cardiomyopathy. This is a strain pattern. And in the tissue Doppler, the E prime velocity is early filling of the RV. So that is increased in constrictive pericarditis, but it is reduced in restrictive cardiomyopathy. This is actually this is images of two patients actually. This first one is the first three are actually of the patient of age 24 years. This patient actually had acute pericarditis. So initially we were seeing some acute pericarditis with some effusion, and then there's calcification also. This patient actually was treated with triple therapy with NSAIDs, then colchicine and corticosteroids. But still this patient was, and so here you are seeing in this the thickened pericardium, and then afterwards still the patient was not actually getting better. So they added actually anakinra for 8 months, and after that this is the final. So the patient got healed after getting treatment with additional treatment with anakinra also. So here what we are seeing is this T2 stir image in cardiac MRI. You see the calcification, no? So that is actually disappeared, and this delayed hyper enhancement in cardiac MRI, that the white color, that is also not there. So that shows that the patient has got completely recovered from this pericarditis. This is another patient, a 44-year-old male, who had a chronic calcific pericarditis, which is actually like a burnt out. So in burnt out calcific pericarditis, this constrictive pericarditis. So here what we see is this the calcification in the final stage we don't see actually, and this delayed hyper enhancement also you don't see in a final burnt out chronic pericarditis, calcific pericarditis. So pericardial compression syndromes, cardiac tamponade and constrictive pericarditis, which we were talking about. So one is the fluid under pressure, and then another thing is a thick rigid pericardium. So cardiac tamponade can be, sometimes it can be atypical presentation like a low pressure tamponade or a regional tamponade also. And constrictive pericarditis, sometimes it can also have atypical like occult constrictive pericarditis and transient constrictive pericarditis, which will be self-limiting. And if you see constrictive pericarditis also there will be some pericardial effusion. So in both tamponade, cardiac tamponade and constrictive pericarditis, there is elevation as well as equalization of intracardiac pressures in diastole. So there is elevation of intracardiac pressure and then is equalization of the intracardiac pressures. So that means RA, LA, RV, LV, there will be equalization of the pressures, PA. So there are other conditions which can have similar hemodynamics like this, diastolic equalization of pressures, where the normal pericardium, it doesn't have time to yield and hence it restrains chambers. So in severe left heart failure, acute decompensated heart failure, severe left heart failure, severe TR, and the RVMI, acute pulmonary embolism, acute mitral regurgitation, they also can have diastolic equalization of pressures and can mimic this constriction. So in management of constrictive pericarditis, transthoracic echo, chest X-ray, frontal and lateral views, CT and or cardiac MRA is also recommended as a second level imaging. It is not for everybody, but it is for those where sometimes echo doesn't give any, is inconclusive. They're not able to clearly make out whether it is a constriction or a restriction. That time we can ask for a cardiac MRA or a CT. Cardiac catheterization is indicated when non-invasive diagnostic methods do not provide a definitive diagnosis of constrictive pericarditis. Treatment is mainstay of treatment is pericardiectomy, and medical therapy for specific pericarditis like TB pericarditis is recommended to prevent the progression of constriction. So cardiac tamponade, as we said, it is a significant compression of the heart by accumulation of either fluid or blood, a clot or pus or gas, singly or in combinations, leading to impaired ventricular filling. So cardiac tamponade can happen even while doing procedures like TAVI, transcatheter aortic valve implantation, or even in doing angioplasty also. Sometimes if there is a coronary perforation, or it can cause actually an acute sudden onset of filling of this pericardial fluid, and then immediately we have to, it can cause rapidity of accumulation, and then immediately we have to remove the fluid, otherwise the patient can collapse. So it depends upon the amount of fluid accumulation, pericardial stiffness, underlying heart disease, and the rapidity of accumulation. These are the factors which determine this cardiac tamponade. So in cardiac tamponade, the classical pattern which we see is, one thing is in pericardial effusion, what you will see is there will be low voltage complex. If you see all the voltage complex, it is like a low voltage complex because of the fluid. So low voltage complex, and then there is a QRS alternance. So here we are seeing this QRS, and this is a normal QRS. So there is an alternance. So there is one thing to it. QRS alternance is not pathognomic of cardiac tamponade. It is actually total QRS, total alternance, which is pathognomic. Total alternance means not only the QRS complex, but the P wave, the T wave also should alternate. Then only it is pathognomic of cardiac tamponade. Otherwise, this QRS alternance can even happen in other conditions like with the VPCs and all. And then in chest X-ray, here we see in cardiac tamponade, what happens is there is reduced blood flow to the pulmonary circulation, and the pulmonary vasculature will not be that much prominent, and there will be cardiomegaly, and then you can see a smooth border of the heart. So the smooth contour will tell you that there is a fluid accumulation. If you can see the intensity is varied. If you see here, it's more intense here and it's less. So that is because of the fluid accumulation. So this shows why there is less pulmonary blood flow to the heart, pulmonary blood flow in cardiac tamponade. So this is an experiment which they did. This is the red one is the aortic flow, and the green one is the pulmonary arterial flow. So what they did is in a dog, actually, in an experiment. So what they did is after this is the initial part where there is the pulmonary arterial flow and the aortic flow are both almost aligning together. So then what they did is they instilled fluid into the pericardial cavity in the dog in just an experiment. So what they found it, when they instilled fluid, suddenly the pulmonary arterial flow dropped, abrupt drop compared to the aortic flow. And then afterwards, after some time, After 2 beats only, there is a drop in the aortic. So initially there is no drop in the aortic flow, and then afterwards it equalizes. So during this time, what happens is there is a shift of the fluid from the pulmonary circulation to the systemic. So that is causing actually reduced pulmonary vasculature in which is observed in pericardial tamponade. So tamponade, one thing is the rapidity of fluid accumulation. So this is the LV, the red color, and this is the in between this thing is the pericardial fluid. So here we see there is a rapidity of fluid. So this is the pericardial pressure actually, and that is 2 and this is 12, and this is 18 and this is 18. So what happens here? This is the acute one. That is the rapid effusion, and this is the slow effusion. And what they actually see is the transmural pressure. The transmural pressure is the LV filling pressure and the pericardial difference between the LV filling pressure and the pericardial pressure. So if it is, see here it is 10, here it is 0. So if it is coming closer and closer, that is actually going for a impending tamponade in a chronic situation where there is slow effusion. So, but in a rapid effusion, that can even a small amount of fluid accumulation rapidly that can cause a critical tamponade. And when in a slow effusion after a limit of pericardial stretch, then it goes into a critical tamponade. So this slow accumulation of fluid, it doesn't cause immediate symptoms, whereas rapid effusion can cause immediate symptoms and hemodynamic instability. So rapid collection of fluid can happen in hydrogenic, like in during cardiac procedures, like coronary perforation or causing in TAVI procedures, or even in mitral valvotomy also sometimes they can have pericardial effusion and tamponade. And traumatic, and then dissection of aorta, especially type 1 aortic dissection, where there will be rapidity of blood accumulation in the pericardial sac. And this is one condition where you should not tap. So that's what they say. It is contraindicated in type 1 aortic dissection, causing accumulation of fluid in the pericardium. Acute MI, this is all acute conditions. Then chronic is a infection, uremia. So they usually tolerate for a long period. And then finally, the large effusion, and then they go into a imminent tamponade. So that is in brief about acute pericarditis, pericardial effusion, constrictive pericarditis. Pericardial masses, it can be either primary or secondary. So here again echo, and then cardiac MRA is preferred for characterization. CT scan can be done alternative to cardiac MRA. So depending upon the tumor, surgical chemotherapy and radiation is specific to the diagnosis. So if there is a pericardial effusion, we can actually see in the pericardial fluid cytology, if there are atypical cells, then it will suggest for malignancy. So most of the times it is actually like a stage 4 metastatic cancers. So this is just a brief overview. Acute pericarditis clinically, to evaluate, then imaging, then initial management. If it is not responding, then adding add-on drugs, and then finally refractive cases to consider radical pericardiectomy. In pericardial effusion, finding out the cause for the by pericardial synthesis, and then if it is recurrent pericardial effusion, then creating a pericardial window, and then treating for the cause. Constrictive pericarditis, finally, it is actually pericardiectomy, which is this thing. In one thing in constrictive pericarditis, we should not give beta blockers more, because the tachycardia is a normal response to this phenomenon in constrictive pericarditis. Digoxin can be given if there is constrictive pericarditis associated with atrial fibrillation with fast ventricular rate. To reduce the rate a little bit, you can give digoxin, but avoid giving rate reducing drugs in a patient with constrictive pericarditis who is having tachycardia. And the diuretics also we should be giving in a limited dose only, in a low dose only. Thank you. Diastolic means T is a tumor block. Tumor block, which you hear in myxomas, no? LA myxoma. This is. Just for remembrance, and it goes in that order only. So if they ask you the difference between opening snap and S3, you can say S3 occurs after opening snap, like in that order of frequency. Phonocardiogram, no? In that they find out that it occurs after this tumor block.
Insertion ideally how many days?
2 to 3 days. 2 to 3 days. And then every 4 hours to 6 hours, we actually better to aspirate and see. And then sometimes what happens is the position may be, so you have to adjust the position, and then so we usually remove the pigtail when the drain is less than 20 ml per day, and then for 3 days, and then patient is also symptomatically better. So that time actually we have to do an echo actually, and then see whether the fluid has come down or not. And usually the fluid accumulation above the right ventricle, that only we will be able to aspirate. So if there is still fluid accumulation is there, then what you do is you reposition it. So reposition cannot be done just like that. You have to go to take the patient to the cath lab and then insert a wire inside the pigtail and then adjust the position and then give some saline and see whether there is any block or like that.
After this repeated aspiration, even the persistently the patient accumulating fluid, then the pericardial.
Yeah, like that. Sometimes they, yeah. If it is a pericardial, if it's a pleural effusion, they instill talc and oxycycline and all, but we don't do those things for pericardial effusion. Usually it doesn't, I have seen it doesn't, at least even if it reaccumulates, it doesn't go into impending tamponade most of the times. Malignant pericardial. You have to treat that primary disease with a surgery, chemotherapy, like that. Surgery may not be, because once it is a malignancy, it's already metastasized. So they'll be giving chemotherapy and radiation.
Basically, we had one patient in the ward, angiosarcoma secondary to that developed impending tamponade pigtail. And then she'll be continuously having this fluid accumulation. That kind of.
If it is like a, but once you remove the, usually if it is a large pericardial effusion, we have removed around 700 ml, 500 to 700 ml like that. So once you remove significant amount of fluid, then there may not be a necessity to keep the pigtail for a long term. Long term is also not recommended. Patient will be feeling uneasy also. Patient won't be able to sit also and then walk around also. That is also harmful also sometimes. If it can injure the this thing, the pigtail can come out also. Like, so always when you have a pigtail, within 2 to 3 days itself, better to remove, and it should not be removed just like that. It should be patient should be taken. Echo has to be done and taken to the cath lab. Then what we do is we put a O35 wire inside it, and then when it comes, the wire comes out of the pigtail only. Then we remove it.
If the pericardial drain is significant, like 50-60 ml per day, still drain of this, even though you will remove it after 3 days, how will it work? So we have a case of pericardial.
You see the diastolic collapse, the RARV collapse. If the RARV collapse is not there, patient is symptomatically better. You can keep it for, it is not that dictum that the 3 days, but you can keep for some more days. But usually it resolves when you keep aspirating and treating the cause also simultaneously. There's no guidelines like that for this thing. But long term, usually we don't infection and these things are complications. But most of the time, to my knowledge, I have seen that it doesn't require actually long term. And even if it accumulates, it won't be like, it doesn't accumulate that much if you are parallelly treating the cause also.
TB pericarditis, we give Dexa to prevent constrictive. Is there any other drug
in TB, yeah. So corticosteroids in TB pericarditis actually is not, there's no clear cut this thing, but early stages, if it is given, it will be helpful.
Not all patients go for constrictive.
Not all patients, but they in Ronald it says around 20 to 30% can go in. Even if you are treating with ADT, and they are telling that ADT beyond 9 months of ADT, it doesn't give much of help. Even if you're extending the course of ADT doesn't help. So recurrence can this thing progressing to constrictive pericarditis can happen in 20 to 30% of the patients, even if it is adequately treated with ADT. Usually in yeah, it can be given initial period. Other than steroids. This immunosuppressants which they are giving like azathioprine, those things and all, I don't think that is given for this thing. One more thing in HIV pericardial effusion, we should not give steroids. It seems it increases the risk of malignancies. There is a sentence like that in Ronald. HIV patients. HIV patients, we see a lot of patients having pericardial effusion. They rarely go into constrictive pericarditis. The reason I don't know, but that's what they mean. Tuberculosis we see very common. And after pericarditis, they become better actually. The patient is having constrictive pericarditis features and all. Otherwise, it is very difficult to treat. We don't have much medical treatment for that. Only diuretics symptomatically. That also we cannot give that much. And then heart rate also we cannot reduce that much. So, thank you for your patient listening.